Hello and welcome to this part one of the video series looking into management of Achilles tendinopathy in runners. Now, this is really an extremely common conditions which we see in our clinic, especially if we're dealing with runners, and especially if we're dealing with the 40+ runners. The more mature runners tend to have this. And although it's very common, it can be quite frustrating in many runners and tends to linger on for a long time. So in this series is the most comprehensive series that I've ever done. We'll go through the entire journey, right from the beginning, etiology, the presentation, the different stages, classification, and also most important, looking at the management, right from the early stages to end stage plyometrics, and also return to running as well. So let's start from the first part. So a brief introduction. I'm a physio, deal exclusively with lower limb, and I'm also the editor of the Hip and Knee Pain Disorder, a best-selling physio book on Amazon. I've been involved with running and rehab for the last 9 to 10 years, and with specialist area with lower limb, especially hip and groin. Now, in this presentation, we'll be looking into mainly sort of application in runners. So Achilles tendinopathy can happen in both active and inactive patients. But for the purpose of this talk and the following talks, we'll be mainly looking at Achilles tendinopathy in recreational runners. And we'll also look into how that sort of looking into the top training errors. So what are the key factors which we need to look in the subjective history? And most important, we'll be having a look on the management strategy right from the early stage and all the way to sort of end stage, and plyometrics right from your early isometric, heavy, slow resistance, eccentric, and also going into plyometrics, and also looking into some practical applications. Now, how common is the problem? So if you look at the literature here, you can see it's definitely an ongoing issue. Sort of about 9 to 11% of recreational runners tend to have these issues, and especially if you're dealing with high level, like elite runners, it can go as high as 52%. And interestingly, around 30% may not improve with conservative management. There are many reasons for that, which we'll explore at a later stage. And also the recurrence is very high. We know one of those bigger risk factors of running injuries is previous injuries. So if they had the same injury many years ago, they're more likely to have it again. And Achilles tendinopathy is also common in the sedentary population. So people, especially linked with obesity, diabetes, those conditions can also predispose to Achilles tendinopathy. Now, a brief look on the anatomy side of things. So if you look at sort of the Achilles tendon, although it's one tendon, which you can see here, it's made of specifically 3 parts here. And the soleus has an important element here. So if you look at the cross-sectional area, the soleus has 6 times the medial gastroc, 2 and 1. So an important number to remember with Achilles tendon is 6 to 1. The physiological cross-section area is much larger than the soleus. Next is the medial gastroc, and then the lateral gastrocs. So this has important application, because when we look into the rehabilitation, we need to be making sure that we are focusing quite strongly on the soleus muscle, because the larger the cross-sectional area, the more likely you're going to generate the force. So the force production is linked with the cross-sectional area. So the anatomy gives us clues on the rehabilitation focus as well. So so definitely we don't want to be missing on loading the soleus, especially when we sort of push them into the heavy slow resistance at a later stage. Now let's look into the running population. So when we look specifically into the running population, we know that it's extremely common. And about a third of runners develop persistent symptoms after new onset. So a lot of patients still have symptoms for a long time. And some studies shows it can go even up to 10 years. And so this is a prospective large study which looked at sort of ongoing, about more than 1,929 participants. About 5% had symptoms, and they still reported, about 30% still reported after 1 year. So it can persist for a while. Now, one reason could be is because it's a heterogeneous group. We're talking about different types of people with Achilles tendon issues. So a very interesting sort of research, which was published in the Journal of JSPT, which sort of came out recently, looked into the subgrouping of Achilles tendon. And this is where I think the research is going more, is looking what is the different types of categories of people and how can we help them. So when we look into the categories, the researchers looked into symptoms. They looked at hopping test pain levels, the VISA score. They looked at lower extremity function. They looked at patient-related outcomes like BMI, age, sex, the function, especially like the drop jumping, single leg jump, psychological factors, and tendon structure. So I would say it's a very comprehensive sort of assessment, which might not be always possible in clinical population, but obviously for research purposes, they had to be very elaborate. And they looked into sort of this, based on these factors, they sort of divided patients into 3 groups: activity dominant group, psychosocial dominant, and structure dominant. Let's explore these 3 in detail. So when they looked into activity dominant, this was the largest subgroup, and they were quite young. They had low BMI, quite active, so more likely to have the running population. And they had the lowest kinesophobia, and they had responded well to progressive loading. So this is quite important. These patients generally have good outcomes here. Now, the next group which we are seeing here is the psychosocial dominant. They had quite poor quality of life, predominantly high females. The symptoms were quite severe, and there was quite a bit of issue with the psychological element. So obviously, from a treatment point of view, we need to address more on the beliefs and fear. And the third group was structure dominant, a bit more older, generally high levels of males. They had quite a bit of thickness. So when you looked at ultrasound, they had quite a bit of thickness. So the normal sort of size of the Achilles tendon ultrasound is around 4 millimeters. So generally, if anything more than 6 millimeters is considered to be significant. So they had more structural changes. And they're more likely to have other morbidities like diabetes, cholesterol, and things like that. So I think next time you see a patient with an Achilles tendon patient, so look into the sort of subcategories. Are they more the younger, mildest types, quite active with less kinesophobia, whereas or the psychosocial dominant, more female, high BMI, poor quality of life, and greater psychological response, or who have more issues with the structure, a bit more older, generally male, and also poor functional deficits and poor quality of life. So obviously, this is not a strict criteria, but it sort of gives you an idea of the different subgroups which we need to really be aware of when we are dealing with Achilles tendon patients as well. So that is specifically looking at patient classification. This doesn't tell us about the cause of Achilles tendon, but it looks into the patient subgroup. Because, for example, if you're dealing with a more activity-dominant group, the younger, milder symptoms, then they do really well with progressive rehab, and you can be a bit more aggressive. The second is the psychological dominant group, which is sort of which has biggest psychological response. So we might be important to address the beliefs and fears and focus on improving quality of life and function. The last one, where we have to look at the bit more aged population, look into the medical factors, look into lifestyle changes, and start at a very low level. So whereas the activity dominant, we might start at a higher level. In structure dominant, it might be at a lower level. So again, it's going to be different for different patient groups. And what causes Achilles tendinopathy? So I think we can sort of put them into two groups: internal intrinsic factors and extrinsic factors. So like with anything, it's usually always a combination of internal and external factors. And when we look into Achilles tendinopathy, it seems to be linked with age. So we know that most tendon issues tend to be more involved in the 40 plus. And we also know there's a strong gender bias. So if you look, if you take 100 patients with Achilles tendinopathy, 70 to 80% will be males. So there seems to be a gender bias as well, and also linked with high BMI. So if you link with obesity, high cholesterol, metabolic syndrome like pre-diabetes, they can also lead to factors, and it can also be linked with some drugs, some set of antibiotics. And we should not forget about muscle function. So if you're dealing with sort of muscle function like weakness of the gastrocsoleus complex, ongoing imbalance to previous injuries, external factors, hugely important runners. Had they had a sudden change in the training volume, especially in speed? Have they changed the shoes? Have they had change in the surfaces? Those things are really relevant in a running population. So have a look into those sort of risk factors. So you get a patient in your clinic with Achilles tendon. Is it because of just overtraining or pre-existing weakness, or other metabolic factors as well? So it'll be different for different patients. And let's not forget, with any running injuries, the most significant one is previous injury. So sometimes, that is the key reason. Maybe they didn't complete the rehab properly. Maybe they'd gone through a very short course of rehabilitation, and that was not enough to sort of get that full return to function. And we did mention about metabolic factors. So I think there's a sort of a general view that tendinopathy is just a load issue, but we know conditions like diabetes has a high risk of. So if you have type 2 diabetes, your risk of developing tendinopathy is about 4 times, and the risk of getting tears and ruptures is 5 times. So those systemic factors like diabetes, smoking, thyroid is something we need to be aware of, because those patients might have a slower recovery, and they're generally intrinsically higher risk. So if you have 2 runners, so if you got like 2 runners, both are 45, one is diabetic, poorly controlled, that could be an issue as well. So again, looking into those factors and explaining to the patient that tendon health is directly linked with metabolic health. So you can see here patients with without diabetes, how the structure, in patient with tendons, in diabetic patient, there is sort of issues with the collagen matrix organization. So there is increased scar tissue formation in type 2 diabetes, which might be increased with an increased risk of ruptures or impaired restoration as well. So those factors are really important to look at. One of the things patients really complain is they look at swelling. Sort of one of the things which is a recent article looked into, how does it change structure? So one of the patient's key symptoms is when they get up in the morning, it's stiff. So we know that pathological tendon is swollen and it's a bit more thicker. It doesn't mean it's stronger, it's mostly with fluid. So at rest, more fluid is drawn into the tendon, and while they're sleeping, and when they stand up in the morning, it can result in pain and stiffness. This is quite common in many tendons, especially in Achilles. You do also see this in plantar fasciitis as well. And once they start moving and start warming up, then the pain warms up. So the runner will say, it's a bit stiff and painful, but when they start running, it becomes less painful. This is classical tendon pain. So again, gives you the sort of the confidence that we're dealing with Achilles tendon. So a healthy tendon is generally unswollen, less fluid, whereas a pathological tendon tends to be larger, thicker, but not stronger, but more of fluid. So the fluid, attraction of fluid is quite a common sign, which you see with patients with Achilles tendinopathy. Next, we need to be looking into a classical reason for sudden increase in injury. So a common mistake we see in runners is too much, too soon, too fast. So they've increased their running volume, they sort of, or they change the surface, and they change the capacity. So I'm going to give you 3 key tips here, while we don't want to be missing that while we're dealing with runners, especially in the recreational population. First thing is speed. So speed is a key factor. So when we increase the running speed, it tends to lead to greater peak forces and more effort, especially on Achilles tendon. So the cumulative load was higher in speed. So when a patient comes with Achilles tendinopathy, we want to check, have they had any increase in speed work in the last 3 months? Have they been sort of having a spike in training volumes? And running at fast speed without adequate recovery can potentially lead to at higher risk of developing Achilles tendinopathy as well. So maybe the recovery is not adequate. Maybe they didn't have the strength reserve, and maybe it was too much too soon. So that's one of the first thing I would check is the speed. Have they had any increase in speed? Next element which we're going to look at is the surface. So this is very important research from Professor Carsten Knobloch from Germany. I've met him a few times, a fantastic speaker. Highly recommend if you get a chance to hear him speak. And he's been dealing with this area for a very long time. And this is something which I find clinically is, if you run on soft surfaces, especially on sand, it increases the risk of Achilles tendon by 10 times, especially if you're 40 plus. So in most of the running literature, if you're 40 plus, it's considered to be a master athlete, whereas it's less if you're running on a harder surface like asphalt. So why is running on soft surfaces? So people generally think running on soft surfaces is good. Of course, it can be useful in certain conditions like bone stress or some of the knee conditions, but generally with tendons, it tends to increase the risk. Let's go through why that could be. A common question people ask is, should I train in sand or softer surface? Is that not better? The problem is in sand, you cause greater deformation, and there's more demand, on the muscle system, less recoil. So the tendon has to work harder when you have, longer contact times. So when you're dealing with a soft surface like a sand, the properties of the tendons are not really efficient. They have less contact times, less elastic recoil. It doesn't really work as a spring. And that is not efficient because we know that tendons are like a spring. So the solid ground, if you're on a hard surface, it resists deformation and creates a sharper stretch and a greater structural flex. So I'm not saying not to train in sand, but if you got somebody with an Achilles tendinopathy, one of the things I always say is to reduce the training on soft surfaces, especially if they're running and it's raining the day before. Avoid raining on softer surfaces, which could potentially flare up symptoms in patients with Achilles tendinopathy. So first was speed, second was the soft surfaces as well. And we also know that running with softer surfaces leads to other adaptations. So one, it decreases the range of the knee and the ankle. So this was a study which looked at 11 male runners and made them to run on uneven surfaces. And also it sort of reduces the output of your plantar flexors. So it becomes less effective. And also the peak forces of the soleus and the gastrocs is less. And there's more activation of the proximal part like your biceps femoris and vastus lateralis. So this is something to bear in mind. So the output of the calf is reduced. When you have less knee flexion range, then the shock absorption is also affected. So this is all the sort of factors to consider if they run on unstable surfaces as well. The last one, which is sort of equally important, is shoes. So if you're going for a very minimalistic type of shoe, so you can see 2 examples. One is a Nike Air Zoom Pegasus, a very popular shoe, whereas you go for a more minimalistic style like some of the barefoot style, like the Vibram Innova style. So they generally tend to have a low stack height, possibly a less drop, and that increases the loading on Achilles tendon, especially if you have not had enough time. So generally, if you want to make a transition, we're talking about 9 to 12 months. So if you made a big jump from a well-supported shoes with good stack height and also a traditional shoe to a more minimalistic shoe, that could also increase the issues as well, especially if you're not given enough time to build up your intrinsic and the calf muscle strength. So also asking with your runner, have they had any change in their shoes recently? Have they changed the style of shoes for a more minimalistic style as well? Because that's something to bear in mind. And when you talk about the shoes, we naturally ask about foot strike. We know that when we runners with so generally you have three types of foot strike. You got heel strike, midfoot, and forefoot. If you make a sudden change, so we see this in clinic quite a bit, where patient with a long-standing knee pain tends to make the transition to like a midfoot, forefoot too soon, and that puts a lot of strain on the calf complex and the Achilles. So we have to remember, so the forces are much higher on the foot and the Achilles tendon when you go to a forefoot. I'm not at all saying that that is not a good option, but again, it depends on how much time they had. Have they made that transition slowly along with some appropriate strength exercise as well? So again, if they not had that sort of transition, and if they had gone into forefoot, that could also be one factor. So going specific to runners, just to summarize here, don't forget about the 3S. Speed. So have they had an increase in speed? Have they had a sudden change in the surface? And also with shoes as well, if they're going into more minimalistic shoes. So again, it's just building up the picture. What are the risk factors? So age, the BMI, metabolic factors. We're looking at training errors specifically. So with runners, the two key areas which we don't want to miss is previous injury. Have they had Achilles pain before, or are they sort of had any recent spike in training volume or surfaces, or are they doing a lot of trail running, or they do sort of more softer surfaces, or change of shoes or foot strike? And we talk about change in load, we're talking about volume, intensity, speed, duration, hills, and things like that. So that gives us a good idea which are the factors which could have potentially led to that. So that sort of concludes the initial talk, where we just give you a bit of a flavor of the etiology, the risk factors, and also some specific running related factors, which is sort of linked with the recreational population. In part 2, we look a little bit more on the diagnosis, assessment, and other elements. And 3 and 4, we'll be looking into the management. And 5 and 6, we're looking into the end stage, the plyometrics, return to running, and also adjuncts, which might be useful as well. So this is part of the most comprehensive series that I've done on Achilles, and I'm looking forward to seeing you on part 2.